So welcome to today's Let's Code Together session. The first slide explains that MEDRA came about in the mid-1990s. It was an ICH initiative, and at the time the MSSO was put in place to maintain and distribute MEDRA. The activities of the MSSO are overseen by a management committee with representatives from both the ICH pharma industry and regulatory authorities. This is a copyright notice. The slides are not made available today, but you're welcome to use our MSSO materials. We only make the recording available. However, if you quote anything or use anything, you must acknowledge ICH as owners of the material and of MEDRA. If you change anything, it's your responsibility and you have to indicate how it's been changed. I mentioned that we'd like to make this session a workshop, so we invite you to use the questions pane to ask questions and comment on our proposed coding of the examples. We may not all agree on the term selection, and sometimes in the interest of time we have to agree to disagree. We can't take requests for you to code specific verbatim terms today that you've suggested, and you may have sent some in this week. We can't take them very short notice, but we will consider them for future versions of the webinar. And at the end, there will be an option for you to propose new examples, but please make sure these are of general interest to the wider audience. We can't take terms which are very specific therapeutic area. So this is the polling. The easiest way for you to join the quizzes or the polling is to scan the QR code that you see here on the right-hand side of your screen. Or you can open an internet browser, either on your computer or your cell phone. So this is something like Safari or Chrome, not Google. It's a browser, and you enter in the URL pollev.com. Then you enter JaneKnight855 as the username. It's completely anonymous. You don't need to use your own name, and then you can click join. That will link you up to the presentation today, and you'll be able to express your views in the voting. If you miss the connection, just let us know and we can show you the QR code again throughout the session. So the first poll gives you a chance to practice on your phone or I see somebody's joining us, Australia, India, lots across Europe, Russia. I can't make out Europe, so much detail. Nobody from North America today, the Independence Day. Perhaps wasn't a good day to choose, but welcome. Wherever you are in the world, welcome. Korea, Philippines. Oh, North America. Happy Independence Day to you in North America. I'm not sure, is that Catherine who often joins us? Whoever you are there. Oh, Canada. We got Canada. No, Canada. Look again. I'm missing your geography, Carol Ann. Let's move on. So this is the demo for the web-based browser. You can use this if you don't have access to a browser, you don't have your credentials to hand. This is one we've created for the session. It will be valid until Friday of this week, but you're not obliged to use it if you've got another one. Challenges, sometimes coding, we find there isn't an exact match. Sometimes there's more than one possible LLT that we could select for a term. And even the points to consider document offers us options sometimes in places. Sometimes we understand terms differently, and Carol Ann and I find this when we even look at the examples in preparation for the session, we have a different understanding of what's actually being reported. So what we do when we code is we represent events by the best approximation that we can make. And overall, we always code as reported. Even if we do the best approximation, we never make assumptions. And we often say that it's a case of using your medical judgment, and you get these pictures, don't you? If you look at this picture, sometimes I can look at it one way and I feel that the squares are leading inwards and they're facing a certain angle. And then if I turn and I look the other direction, the boxes seem to turn and point another way. And we find that verbatim terms are just like this, like these optical illusions. You look at them twice, or someone might highlight an element of the report and it makes you see the term in a completely different light. So that's what we're trying to say here with this. Medical judgment is often needed. It's a balance between applying rules, and we'll highlight some of the rules today that give us consistency in coding, medical judgment that help us be as accurate as possible, and also to manage the risk to patients, and that's our ultimate goal. Medical references may be helpful in understanding reports and making decisions on coding, and you will highlight some references today. And sometimes it may even be necessary to request that a new term is added to MEDRA to represent the reported concept. So with all that, let's code together. And I'm going to switch off my video now so that we can focus on the examples, because it can be distracting. So Caroline, I'll hand over to you for our first set of examples today.
Yes, I will share my screen. Just a moment. Here we are. Can you see it, Jane?
Yes, I can see that.
Perfect. So welcome again, and here's our first verbatim. It was postponed from last webinar for discussion today due to time constraints, and it was actually proposed by a previous attendee. A renal disease causing hypertension is reported. So is this verbatim clear? Do we understand what has happened and the chain of events? Is split coding necessary? And what would be the most appropriate LLT or LLTs? So how would you approach this verbatim? How would you code it? Renal disease, hypertension would be an option, renal hypertension, renal vascular hypertension, renal parenchymal hypertension, hypertensive renal disease, or hypertensive renal disease unspecified. What would you do? Let's see what you're going for. So most of you would split, obviously, renal disease, hypertension, but others would also go for renal hypertension. So this is the favorite selection here, renal hypertension. And let me close the poll here. So here we are. Well, what is reported in our case? So hypertension itself can, of course, cause renal disease. And renal disease can cause hypertension, vice versa. Both options are possible and valid medical concepts. In our case, the kidney disease led to hypertension. It was not reported that the hypertension existed first and then caused the kidney disease. So let me switch to the browser here. Here we are. Here's the browser. You need your MEDRA ID and a password to log in. And here we are. So some of you have voted for splitting. Renal hypertension, of course, is available in MEDRA. Here, renal disease, renal disease. Because this renal disease, it was not specified, caused the hypertension based on our verbatim. Here it is. It's grouped under PT nephropathy. And if you click on it, you see it's grouped in renal and in the SOC renal and urinary disorders. Of course, there's also a term available in MEDRA representing hypertension, unspecified hypertension. Here we are. And it's grouped in vascular disorder, same PT. So we could split code, yes, but we may lose the causal relationship between both conditions when doing so, depending on the structure of the respective database. So let us look for combination terms by searching for the strings renal and hypertense. So ren and hypertense to capture hypertensive and search. It's always good to use word stems. Hypertension renal would be an option here, so renal hypertension. And we see that renal hypertension is grouped in primary stock, renal and urinary disorders, and has a secondary linkage to vascular disorders. So when I do a right mouse click, say go to browser, and click at this on this LLT, I will be brought to the hierarchy. Here we are, renal hypertension. And under this PT, you see terms like hypertension secondary to renal disease, antepartum, postpartum. So this is exactly what has been reported, a hypertension secondary to renal disease. So this seems to be the correct code assignments. Renal parenchymal hypertension would, of course, be too specific. We don't know whether it was a vascular hypertension or parenchymal hypertension. So this would be too specific. Same holds true for renal vascular hypertension. Hypertensive renal disease, where is it? Here it is. Hypertensive renal disease would be used when a hypertension has caused a renal disease in the patient. So this would not be correct. So then the hypertension would be the first disease in the patient causing a complication, the renal disease. In our case, a renal hypertension was reported, meaning the renal disease existed first and caused a hypertension at the end as complication in the patient. And so we have found a suitable combination term that really perfectly captures what has been reported. And if I look for hypertensive and only search for PTs, for instance, you will see that MedDRA always offers a lot of combination terms, like here, hypertensive angiopathy, cardiomegaly, cardiomyopathy, crisis, emergency, nephropathy, hydrocephalus, retinopathy, hypertensive. So a lot of options that are provided when using hypertensive and looking for combination terms on PT level. Let me switch back to the presentation here. So you saw that MedDRA contains many combination terms, so always search for them when receiving similar reports. It's always worth it. When looking at potentially suitable combination terms, clearly distinguish between the cause and the effect. In our case, renal disease caused the hypertension, not vice versa. So check the hierarchy to reassure yourself that you are on the right track. And here is our final suggestion. We would code to LLT renal hypertension under the same PT. Any questions, Jane?
No questions on that one so far, Caroline.
Thank you.
Maybe just bring in. I think everyone's probably just processing what you've just shown us.
I think it was it's quite clear, this example. So now we are coming to the next verbatim, and here an alcohol misuse of a patient is reported. Well, what does misuse mean in this context? What would be the most appropriate LLT, or do we need to query to seek for clarification? How would you approach this verbatim? Which LLT would you select? Alcohol problem, alcohol use disorder, alcoholic, alcohol use, alcohol abuse, alcoholism, binge drinking. What would you do? Alcohol misuse is reported. So let's again have a look. Yeah, we have a split of opinions here. Not surprising. many terms, many different options, all relating to alcohol use, any alcohol problems. So here we are. Alcohol use disorder is one favorite selection, alcohol abuse the other, but also alcoholism, alcohol use, alcohol problem are considered. So let me close the poll here. So most of you have voted for alcohol use disorder, others for alcohol abuse, and the others were also considered. So let us again check in the browser. Let's look at what we had just have seen. Alcohol problem was one option. Here we are. And it's, let me switch LLT again and search. So alcohol problem is an LLT, same PT. And if I click on this PT and go to the browser, you see it's grouped under substance-related and addictive disorders in psychiatric disorders. And here we have the alcohol abuse, alcohol problem, alcohol use disorder, alcohol withdrawal syndrome, alcohol coma, alcoholism, binge drinking, all the LLTs and PTs that we saw in the poll. So alcohol problem itself is quite a vague term. No further, more specific terms can be found underneath. So it could be anything between moderate alcohol use up to severe alcohol addiction, alcoholism. What about alcohol use disorder? So this is a disorder, so indicates that something, some damage may happen to the patient, but again, there is no more specific LLT underneath explaining what is really meant by alcohol use disorder, whether it's a defined medical condition. Alcoholic, let us look for alcoholic. Here we are. Is a LLT under the same PT, and if I click on it, you can see it's grouped under social circumstances. It's considered a lifestyle issue, alcohol product use. And if I click on it, go to browser, we can see that alcohol product use, alcoholic, social alcohol drinker, these are terms that are grouped under social circumstances. So if you have reported in the medical history of a patient a social circumstance like this alcohol product use, then of course you can use it, but not for adverse event coding. Alcohol abuse was the other option. It's not misuse, it's abuse, but it's grouped under the same HLT that we saw before: alcohol abuse, chronic, continuous drinking behavior, unspecified drinking behavior, non-dependent abuse of alcohol. So this is considered abuse. Alcoholism, here it is, alcohol addiction, alcohol craving. So this really describes a severe alcohol use disorder with these LLTs. So this was not reported for our patient. We don't know whether this is really, this patient is suffering alcohol addiction. And binge drinking, here we are. No further LLT explaining what is meant by binge drinking. You may not be familiar with this term. It's not suitable either because it describes something much more specific. It is defined as consuming 5 or more drinks on one occasion for men, or 4 or more drinks on one occasion for women. Most people who binge drink are not dependent on alcohol, but binge drinking is harmful on its own as it is associated with serious injuries and diseases. So these were the terms that we saw in the paw. Now let me switch back and let's have a look at the concept description for misuse and abuse to better understand what is meant by that. You find the MedRA concept descriptions in the MedRA browser here on the top. If you click on this little icon, then this page will open and you will find the concept descriptions in alphabetical disorder, starting with abuse. Here we are. Misuse. For the purposes of term selection and analysis of MedRA-coded data, misuse is the intentional use for a therapeutic purpose by a patient or consumer of a product, over the counter or prescription, other than as prescribed or not in accordance with the authorized product information. So misuse is referring to medicinal products and is to be used, or something needs to be classified as misuse if it's an intentional deviation from the authorized product information for therapeutic purposes by a patient or consumer. So this is not applicable to alcohol because alcohol is not a medicinal product. So that is why abuse may be much more suitable for our coding scenario, because here we are told it's the intentional non-therapeutic use by a patient or consumer of a product over the counter or prescription for a perceived reward or desired non-therapeutic effect, including but not limited to getting high, euphoria. Abuse may occur with a single use, sporadic use, or persistent use of the product. So this is also applicable to alcohol, of course. And this is confirmed in the Dorland's Medical Dictionary, where we are told that in a general sense, abuse and misuse can be considered quasi-synonyms and describe the wrong use of something, particularly an excessive use. We also found the following reference referring to alcohol consumption in England, where the wording alcohol misuse is used in context of harmful use of alcohol. And in Medline Plus, there is a description of the term alcohol use disorder. We saw that before with no specific LLTs underneath. And my question was whether this may be a defined medical concept. And this is somehow the case. Alcohol use disorder is a general term which refers to the situation where drinking causes distress and harm. And it can range from mild to severe, from alcohol abuse to alcoholism and alcohol dependence. And the reference also provides a description of the word binge drinking I've mentioned before. So that's exactly what I've been telling you about the 5 or more drinks in men and 4 or more drinks in women within a few hours at one occasion. So what can we learn from what we saw? First of all, it needs to be clarified what abuse means in the context of alcohol use, in contrast to what it means in the context of drug use. We saw that a number of PTs exist describing conditions in patients that relate to alcohol use, and some of them are grouped in social circumstances and are not suitable for adverse event coding. Based on all these considerations, we would propose to code to LLT alcohol abuse under the same PT, not making any assumptions regarding the severity of the condition. So do we have questions here, Jane?
No questions about this one, Caroline. There's a couple of comments about people about the difference between drug and alcohol with misuse and abuse, but I believe you've covered that. So if anyone's got remaining questions on that, let us know. Just when you go to the browser next time, can you also repeat how you do the top-down search, and can you repeat where you get to the concept descriptions?
Yep, I will. Okay, next one. More complex verbatim here. Here it is reported that a patient took a broken capsule and the powder on the capsule got stuck in his or her teeth and tasted horrible. Does this verbatim describe a product quality issue or a medication error? Do we have to split code? And what would be the most appropriate LLT or LLTs to capture the information that was provided in this verbatim? So let's have a look at the first part of the verbatim, the broken capsule. How would you capture this information? Would you assign inappropriate removal of drug from capsule, capsule open, capsule physical issue, soft gelatin, capsule burst, cracked product, or would you seek clarification from reporter? Would you query? What would you do? Just looking at the first part, broken capsule. So again, we have a split of opinions here. Most of you are voting for capsule physical issue, but others for capsule open, others for inappropriate removal of drug from capsule, and also cracked product. So all, what else did we have here? And others would query. So let me close this poll and let us again check in the browser. Here are the medva concept descriptions. You see when I click on it, exactly this page opened. This is exactly what you have seen in the screenshot in the presentation. And we will do some top-down searches later on. So you can either search for strings in the search window in the middle of the screen, or you can do top-down searches here, for instance, in substance-related and addictive disorders in order to find appropriate terms for the given verbatim. So we are with our broken capsule. We had the inappropriate removal. If I search for it, inappropriate removal of drug from capsule. If I click on this PT, I can see the hierarchy here, and it's considered a medication error, product use error, and issue. So wrong technique and product usage process. But this would not be correct because it was not reported. Our patient took a capsule despite it was broken. We were not told that the patient, him or herself, has broken or opened the capsule in order to swallow the powder that was contained in the capsule. So this was not reported. So let's search for capsule physical issue in the search field here. Capsule and physical. Oops. And search. Here we are, capsule physical issue. Right mouse click, go to browser, and then we will be brought to the hierarchy. So here is the product physical issue PT under product physical issues. And under product physical issue, you can see LLTs like capsule extra shell, fill abnormal, capsule open. We had this LLT, product burst, product clumping, so many different physical issues contained in this under this PT, represented by quite specific LLTs. So capsule physical issue would be too unspecific because we know that the capsule was broken. There is no broken capsule. There is also no product broken. It's product burst. But product is more unspecific. We know it was a capsule. It was not a tablet. It was a capsule. And if I look at the capsule LLTs that are available under product physical issues, I see the capsule open. So this is the best approximation to what has been reported in our verbatim. Correct product, again, would be too unspecific because it's referring to product. So it does not specify the specific product. In our case, the capsule. It could, so product could relate to anything. Now let me switch back. Here we are. Next part of the verbatim. What else is being reported? The capsule was broken and the patient finally took it, although it was broken. Would you capture this information, and if yes, which LLT would you select? Or would you think that this doesn't constitute a medication error and ignore the information? What would you do? Poor quality product administered would be one option. Self-administration error, drug administration error, wrong route of administration, or would you just ignore this information because you would consider this not as a medication error? Again, split of opinions. Most of you are voting for poor quality drug administered, but others for just drug administration error. Self-administration error would also be an option, and others say, no, this is not a medication error. So let me close the poll again, and let us look into the browser. So poor quality drug administered. Poor quality drug administered. Here it is. Right mouse click, go to browser. You see it has two linkages, one to SOC injury under medication HLGT, medication errors and other product use errors and issues. And because poor quality of the product is mentioned, of course, it also has a secondary linkage to product issues, to SOC product issues. So here we are, poor quality product administered. And here we have LLTs like deteriorated drug administered, out of specification product use. Our capsule was damaged, so it was broken. So this is definitely a product quality issue. It should not break, it should be intact. And the patient took it despite this fact that it was broken. So the drug had to be administered in a capsule, maybe because it was not supposed to dissolve until it reaches the small intestine, because it is harmful to the mucosa of the gastrointestinal tract, so the upper GI tract. The patient shouldn't have taken it. Also, the dose may have been too low because some drug may have got lost when the capsule broke. So this can be considered a medication error. The patient shouldn't have taken this open capsule, only whole capsules. And that's why, that's what is normally written in the patient information leaflets for capsules. Take the capsules whole and do not chew them. In other words, taking this broken capsule represents a medication error, an administration error. And you'll find it under these two SOCs, injury, poisoning, and procedural complications and product issues. And the other option here, poor quality drug administered, would be the best choice because it represents a medication error and contains the information that the drug that was administered was of poor quality. So it's a nice combination term. Self-administration error is also available. Here it is. Right mouse click, go to browser. You see it's also grouped under HLGT, medication errors, and other product use errors and issues. Here it is. Accidental multiple drug administration error, drug maladministration, product administration error, self-administration error. Yes, the patient it was a self-administration, but these LLTs are too unspecific. They do not contain the information that the medication error consisted of the fact that the patient took a poor quality drug. So the other term that we saw before, poor quality drug administered, is much more specific and suitable for our coding scenario. And the same holds true for drug administration error. Here we are, drug administration error. Where is it? Product administration error I have to look for. Here we are, product administration error, and its self-administration error is grouped under this PT. So again, drug administration error is too unspecific. It just describes an error during administration of a product, but does not specify what kind or what type of error occurred. And the same holds true for wrong route of administration. This would definitely be incorrect because the way of taking the medicine was correct. The capsule was to be taken orally, but in whole and not when it was broken. So you would also find product wrong. Where is it? We have so many PTs under product administration errors and issues that I really have to search for this string in order to show you. Wrong route of administration, here it is, go to browser, here we are. Incorrect route of product administration would be this PT, but again, it would be incorrect because this was not reported. So let me switch back. And now the last part. How would you code the last part of our verbatim? Powder got stuck in teeth and the taste was horrible. Would you select dislike of product taste, medication aftertaste, product taste abnormal, or taste perversion? Or would you consider this as no issue with the product taste, and would you ignore this information? What would you do? Powder got stuck in teeth and the taste was horrible. Do we need to code this, and which LLT would you select? Dislike of product taste is one option, the favorite approach here. Others say there is no issue with the product taste, and also medication aftertaste, product taste abnormal, taste perversion. So again, we have a split of opinions. Let me close the poll and again switch to the browser. Here we are. Dislike of product taste. Dislike of product taste. If I go to the browser again and look at the hierarchy here, you see that dislike of product taste is grouped under PT product use complaint. Under HLT medication errors, product use errors, and issues NEC. Dislike of product taste is one issue, medication too hard to chew, product difficult to administer, product difficult to swallow, product label contents complaint. So these are the LLTs that are grouped under this PT product use complaint. Dislike of product taste seems to be suitable, and some of you have selected or proposed to code to this LLT, but in our case, the powder should be administered in an intact capsule without tasting it. So this cannot be considered a product use complaint, because usually you would not taste anything, you would not taste the powder. It was because of the administration error of the patient that he or she tasted the powder. Medication aftertaste. Here it is. Go to browser. Is considered a product quality issue. So this, you see, it's grouped under SOC product issues, under HLT product physical issues, again, medication aftertaste or product aftertaste can be selected. So this represents really a product quality issue and is not suitable for our coding scenario either. Same holds true for product taste abnormal. Here it is. Go to browser. Again, considered a product physical issue, and here product taste abnormal or peculiar taste of pharmaceutical product. This LRT would be selected in cases where the usual taste of a product is suddenly different when starting with a new container or blister, for instance. And assignment of taste perversion here we are, go to browser, is considered a nervous system disorder. So here we are, taste perversion. Taste salty, taste sour, taste bitter. So this would not be suitable because this LRT represents a condition in the patient, a taste disorder, a neurological disorder in the patient, and no such condition in the patient was reported. When coding such more complex verbatims, consider all reported information. Here, the broken capsule and the fact that it was taken by the patient, despite the fact that it was broken. And distinguish patient dislikes from product quality issues. And assign an appropriate term for these concepts only if the patient is taking the drug as directed in the package insert. So with this, here are our final suggestions. We would code to LLT capsule open under PT product physical issue and LLT poor quality drug administered under PT poor quality product administered. The horrible taste should not be coded in this instance because it was only perceived by the patient because of taking a broken capsule. It does not refer to the usual taste of the drug. Any questions here for this verbatim, Jane?
I think you've probably addressed them, Carol-Ann, but I've had some interesting back and forths with a couple of our attendees about was the capsule actually broken or was it cracked? When it says it's broken, doesn't mean it's open, but we've discussed that because the powder came out at some point, whether it was in the mouth or whether it was already partly open, it must have been open in some way for the capsule, for the powder to have escaped. So that's what we had there. The other discussion was about the peculiar taste. Was this a product issue? And you've addressed that one. And another point, Kirsten is with us, Kirsten who joined us last time to present, is with us here and has pointed out that there's some good examples in the companion document that our audience might also want to look at about the poor quality drug administered.
Perfect. Thank you, Kirsten.
And then we had a general question about the references we used, particularly on the alcohol issue before. What would you say would be valid medical references, Carol-Ann? Because we've shown Dorland's, we've shown the UK government health website. So how do you personally evaluate the validity of a web reference?
So usually we first look into the Dorland's because this is the main reference, medical dictionary reference for MedDRA. But sometimes you don't find suitable, more detailed explanations for a given term. So then a useful reference would be the MSD medical dictionary that is available on the internet, the professional version. Let me show you. MSD manual, professional edition, you see, it's available for free. You can select a language here. You can review it in German, Spanish, French, Italian, Portuguese, Russian, Chinese, Vietnamese, Ukrainian, of course, also in English. And you can, here are the topics in alphabetical order. You can also search for your topic of interest. So this is also a very useful reference. And otherwise, I would always, here we are, I would always search for a given, for university, yeah, well-known university like Mayo Clinic, for instance, and government pages where there's reliable information about what you're looking for.
Yeah. Thank you, Caroline. Thank you. I think a lot of our audience probably have their own ideas as well on how it's a hard thing to put a finger on, isn't it?
Yes.
Never patient forums, I think, is always what I would say. Never patient forums.
Okay, then I hand it back to you, Jane.
Then thank you very much, Caroline. Well, that was an interesting example. Lots of elements in that one. So let's switch over now to our next example, which is noticed autistic spectrum traits, in brackets, not formally diagnosed. So what's being reported here? What traits have been seen? Do we need to know what traits have been seen? And is there an LLT that we can capture these traits? The fact that something's been noticed and not formally diagnosed. Is there, what would be the most suitable LLT? These are the questions we pose ourselves when we approach any term. So what do you think? I've selected a few here of the terms from the browser that show autistic spectrum disorder, autism, autistic behaviour, atypical autism, and there may be others at the bottom there that neurodevelopmental disorder or abnormal behaviour. There's more at the bottom, so you might need to scroll down. Broad autism phenotype, neurodevelopmental disorder. So I did a search in the browser before putting the slide together to give you a selection. And we'll go to the browser and have a look at the hierarchy of some of these terms shortly. So mainly, most of you are split here between autistic spectrum disorder and autistic behaviour. I think because the behaviour, you've chosen that one because of the fact that something's been noticed and not yet diagnosed. So we haven't yet got a diagnosis of it. Few of you have gone for this term broad autism phenotype. And a few of you for abnormal behaviour, being more general because we don't yet have a diagnosis. So let's lock this poll then. So that's where our votes are, mixed between autistic spectrum disorder, but the runaway winner is autistic behaviour. Well, let's browse. So I'll go to my browser, again to the website with my credentials. Here we are. So if I do the search for autistic autism, let's see what we get here. So we've got atypical autism, autism spectrum disorder, autistic behaviour. So let's just have a look at the hierarchy for some of these. So atypical autism, we'll miss out the infantile because that's got more information. So they all seem to be coming to the PT when I click up the hierarchy of autism spectrum disorder. Even autistic behaviour, they're all falling under the term, the preferred term, the concept of autism spectrum disorder, autistic disorder also. Broad autism phenotype is different. This one has its own PT. Broad autism phenotype. And I have to say, when I first did this search, I didn't know what that meant. So there seems like there's something different about this one because it has its own PT. It's not grouped with all the others. We can see that. So let's take one of these autism spectrum disorder terms, do a right-hand mouse click and go to browser. So I'm doing that slowly because we've had a question about how to do it. It's multi-axial, so I'm going to take the primary link, which we can identify by the icon. Here it is, and under there we can see all those PTs that we selected for you to choose from. Autistic behaviour is one of those, and then the broad autism phenotype is the neighbouring PT. So what is this one? So when I'm at this stage, my thoughts go to, probably like some of you did when you selected the autistic behaviour, well, the MEDRA Points to Consider document would tell us that when we have a provisional diagnosis, we would select it as if it was the diagnosis, because we don't know what the signs and symptoms are in this case. We know there are some traits, but we don't know what they are. So that might be one approach. But what about this broad autism phenotype? So I'm going to go back to my slides now. So as I say, my thoughts would initially be, well, it's a provisional diagnosis, it's traits, it's suspected of autism, but it's not yet been formally diagnosed. Is it a provisional diagnosis? But hang on a minute, before I do that, I must make sure I understand what this autism phenotype means. And this is where, in doing this session today, I actually fell into that trap of initially preparing the slides and saying it's going to be a provisional diagnosis. And it was only after talking to Carol Ann that we said, well, let's look at this one up. Let's look it up. Let's reference this broad autism phenotype so we understand exactly what it does mean. A phenotype in Dorland's is the observable morphologic, biochemical and physiologic characteristics of an individual, either in whole or respect to a single few traits. So there's that word traits, as determined by a combination of the genotype, so the genetics, and the environment. So it's what the individual looks like. It's what you observe in the individual, maybe a mixture of genetic and environmental. We don't really know. So that's what phenotype on its own means. And then we tried to reference broader autism phenotype to find out what it actually means. And it says here that the individuals with these traits have symptoms of autism, but on a milder scale. So not enough to trigger a diagnosis of autism spectrum disorder. And reading that makes me think, it resonates with what we've got reported. It mentions the traits. It mentions something that you can observe, maybe milder, but not yet triggering a diagnosis. And it says at the bottom that the broad autism phenotype is not an official diagnosis. It describes a cluster of traits which can show up differently in each individual. So that's actually drawing me towards this LLT and PT that I didn't initially understand. Again, further research on it. This is a reference which states that autism spectrum disorder is a neurodevelopmental disorder with symptoms that they describe, and then it distinguishes the broad autism phenotype includes milder subclinical personality and language characteristics. So again, it's mentioning that the phenotype, because it may be found in biological relatives, it has also been found in samples without a known relative with the disorder. So it's that mixture of is it genetic? Is it environmental? Do some individuals living with other family members with autism spectrum disorder display some traits of it themselves? Is that environmental or is it genetic? We don't know, but not necessarily so. So then I looked at the history, and this is something that you can do. I looked at the history when the preferred term was added to MEDRA, which was in version 21. We see here the placement of the term. This is a screenshot from the WebCR tool. This is the tool on our website that you use when you request a new addition to MEDRA, and you can use the tool to do a search and look at the history and the rationale for why these terms were added. What did our team of international medical officers say when they agreed to accept it? And this is what I found. The proposal to add it was approved, and it describes problems with personality, language, and social behavioural characteristics at a level that's considered to be higher than average, but lower than is diagnosable. Broad autism phenotype will be placed as PT to the HLT of pervasive developmental disorders and secondary to another HLT. So what we're seeing here is it is distinguished from the diagnosis of autism spectrum disorder. It is seen as being milder, and it's the observation of traits. So based on that, I like that, and I actually then changed my mind, and I didn't go with the provisional diagnosis. I chose this term. So what we would do there as a learning point is to search for a suitable term reflecting the appearance of a condition or a syndrome, the traits. Research terms which may be unfamiliar to you. As I say, I fell into that trap myself at first. But potentially seek to follow up from the reporter on whether a diagnosis was subsequently made, especially if it relates to your study drug or your clinical trial indication, because it may be that this is early days and the diagnosis hasn't yet been made. So it's good practice if you can follow up to find out perhaps slightly later, was the diagnosis actually made, in which case you could then change your coding to the autism spectrum disorder. So final suggestions, I would follow up with the reporter to confirm if that is possible. Meanwhile, I would select the broad autism phenotype term that we just saw. Now, Carol-Anne, do we have any questions on that one? I'll just pause for a moment while the group processes what we've done.
Yeah, we have what would be a reasonable time period to wait to see clarification from Yelena? What would be a reasonable time period?
I think by the time you've raised it, you've asked them to let you know if the diagnosis, they will tell you are there further investigations ongoing. So probably you could query straight away, and if they will come back with something, and if you need to follow up again, you possibly can. You've opened that channel of communication. What do you think, Carol-Anne, from your experience?
Yeah, I agree. So you could immediately query whether a diagnosis was made meanwhile, because usually the cases take some time to be processed for coding purposes. And if you get more information, then you can follow up.
So a lot of you chose the autistic behaviour, which would seem to be a good judgment when you look at the polling. What I think changed my mind was seeing the placement that all of those autism spectrum disorder terms, even the autistic behaviour, are under that same PT. But this one being a separate PT allows us to distinguish between observation of the traits without a diagnosis and the actual diagnosis.
Yeah. So, especially because it's clearly mentioned that it is not formally diagnosed yet. Yeah.
Yes.
Yeah.
Thank you. Thank you, Carol-Anne. So the next one I'm going to deal with today is granuloma of post-surgery scar. So what's being reported here? What's a granuloma? Do we know off the top of our head what's a granuloma? What they're calling it a scar. They're not calling it a wound or a site. They're calling it a scar. Is that relevant? Do we need to seek clarification here? Is there suitable post-op complication term? They've told us it's post-surgery, but what I immediately think, especially seeing the word scar, I start thinking, is this how far post-surgery? Is this immediate, or is this after some period of time? And is granuloma common at a scar site? That's what crosses my mind. So again, Dorland's, our go-to reference, as a medical dictionary, although there are other medical dictionaries around. Granuloma is an imprecise term applied to either a small, nodular or delimited aggregation of mononuclear inflammatory cells or a similar collection of epithelioid cells. So it's something to do with healing. It tells us about the nature of it, the inflammatory, it's an inflammatory reaction, a chronic inflammatory response that can be initiated by infectious or non-infectious agents. So it's a chronic inflammatory. So again, the word chronic to me suggests that it's over a period of time. It may not have happened immediately. A scar is a mark remaining after the healing of a wound or other morbid process, like some kind of injury or wound of some kind, after healing, after an early event. So scar itself, if we can take it that it's correctly used, it does suggest a period of time has elapsed. So let's browse again. Let's have a look for granuloma. We always start with the words that the reporter has used. So let's see what we have for granuloma. We're going to have, we've got 162 granuloma terms. Well, that's a lot to look through. So I'm going to narrow it slightly by putting site in and see what we get here. So we've got application site, administration site. So MEDRA does include some granuloma terms specific to procedural sites: administration, application, catheter, injection site, infusion site, stoma site, vaccination. Well, let's have a look at some of these. So generally they have their own PT, catheter site. There isn't one for incision site or surgical site or post-op. Stoma site. Stoma site has its own, it has its own PT. The others, or hypergranulation, is the stoma site. That one is the only one in this list which is different. So stoma site is hypergranulation. Now this is making me think it must be something to do with overgranulation, abnormal healing. So I can't find a granuloma at the precise. Let's look up incision. No, nothing with incision. Let's look up post-operative, nothing there. And the other one is wound. Let's look up wound. No, nothing there. So I can do these. There is one that I will show you that I found, and I found it through looking through all the list, which we won't go through today. But one interesting one was suture granuloma. Now, when I looked through the list, I found this suture, and this made me think, well, suture suggests a wound. It could be related to the sutures, that the scar has got this problem. So this one jumps out, and I've got that one in my mind as well. But at the moment, I'm not feeling I found the perfect term. So I'm going to do another search now. Let's look up granulation, because we saw that the stoma site was going to hypergranulation. So let's look what we can see with granulation. So we've got granulation tissue, hypergranulation, stoma site granulation, toxic. Excessive granulation tissue is the PT. So that suggests that there's an abnormality in healing. Let's go along to that one and see what it looks like. Right-hand click, go to browser. Oh, there we are. Excessive granulation tissue. So this is in the skin disorders. We've got excessive granulation tissue, hypergranulation, overgranulation. So because the stoma site granuloma was coding to a granulation, it's making me think that this might be something worth selecting, because we can't do a wound site. So let's have a look where we are now. So if I asked you now, which would you select? Healing abnormal, excessive granulation tissue. I've made it easy for you because I've done the browsing before giving you the quiz, but see which of these you would select now. Remember, there may be some off the screen. You might need to scroll down when you select. So there, a number of you are going for the post-op wound complication. Excessive granulation tissue, where surgical site is too vague, isn't it? Operation site inflammation. Well, although we know that a granuloma is an inflammatory response, that's possible, but I have this niggle in my mind about the timing of it. The timing at which, and then suture granuloma, some of you have selected. How quickly after the operation did this occur? So thank you for your votes there. Granulation tissue. So I'm back to Dorland now, because the browser pointed me towards granulation. Granulation tissue is the newly formed vascular tissue normally produced in the healing of wounds. So I got an understanding of what that means, and it can overgranulate, have too much granulation tissue, and the surface of the skin hasn't had chance to heal across the top. The wound heals from the bottom up, and you have too much of this granulation, which leaves it as an open sore. What is a stitch granuloma? Well, that's a foreign body granuloma occurring around a buried, non-absorbable suture. So if we looked at the hierarchy measure, we see this is related to foreign bodies. It's a foreign body granuloma around a retained suture or part of suture. So we don't know that. So I can't make the assumption that the wound, the post-op site, relates to the suture. So my learning points here, I've taken you round a number of options. I would search for granuloma terms, which you saw me do, and I would check the hierarchy. I would then consider synonyms, either through using Dorland's or looking at the hierarchy of some of the other terms in MEDRA, which you saw me do with the stomacyte term. It then broadens my mind to what might be a synonym. I would understand the meaning of granuloma in the context of post-operative complications, and by that particularly I mean how I then discounted the suture granuloma. And I would also consider in my mind how long after surgery the complication has arisen. You may have the date in your patient record to know whether it's a long-term thing or whether it's quite immediately post-op. But overall, weighing up all of that, I would code to excessive granulation tissue. Some of you might say this is a skin disorder. You're losing the idea that it's related to surgery, but the fact that it's granulating implies it is healing. And I would also ensure that the related surgery has been captured, either, for example, in the medical history, or if it's just been done as a procedure related to an adverse event or the adverse event itself. So that's what I would do with that one. What are your thoughts, the rest of you that are out there in the group? What do you think? Any comments, Caroline?
Yes, there are some comments, Jane. So Martin is saying, what about granuloma skin in order to capture the affected site plus surgical scar? Yes. So surgical scar.
Yes, you could do that, couldn't you? That's true. You could do that. Yeah. Granuloma of skin, yeah. I went for the granulation tissue because I suppose I liked the idea of the healing being abnormal, but you're right. Your suggestion is probably closer to the wording we've got. While you read out the next one, I'll just go and have a look where it is. There's the suggestion, granuloma skin. It has its own PT and it's under granulomatous and deep cutaneous inflammatory conditions, dermal and epidermal within skin. So yes, that's another good option.
We like the excessive part of this PT because it's already a healed surgical wound, so it's a surgical scar, and usually you would not have like this excessive granulation tissue on a scar. That's why we preferred this one.
The healing.
But you're right.
Yes, yeah. Excessive healing, as you say, Caroline. I felt this captured the fact it's something that's still healing or just healing or just has healed. Yeah.
And Uma is saying, well, what about post-operative complications? But this would be much too vague. So we would try to capture the granuloma part as well.
Maybe you mean to capture that one as well, use a second option, which you could do, but it, as Caroline says, it's so vague. I felt that if we capture the surgery and we capture some way the granuloma, then we've captured both.
Yeah, Rafi does not agree with the skin granuloma because the terms do not indicate if it's on skin or the mucosa, for instance.
Yeah. That's true. Yes, that's true. And although it goes to the skin sock.
Yeah.
Oh,
so and there's one other comment that relates to the previous part, to the previous verbatim, but it may be worthwhile to show, Jane, because it may be of interest for the wider audience as well. So could you show where to find the history of approved change requests or also rejected change requests?
Yes, of course. So I would go to the MEDRA website here and I would go how to use change requests. It's an option when you do a drop down how to use. This whole page is given over to the change request process. This is where a Medra user has the option to send us a proposal for a change to a later version, to an upcoming release of Medra. On the right hand side here, I have a link, bottom right hand side. You see, we call this the kiosk. This one here, submit change request, web CR. So this is the link to the tool, and I would click on that and it takes me to the logon page. Here you need a special password. It's not the password we've given you today. You can't demo it. You need the organization, your own organization's change request ID, CRID, and that's what you need for the password. Then I log in. And again, on the right-hand side, one of the options here is to search change request history. I can click on search change request history and it brings me here. I can type in the term I want, which was, I probably did it. Did I do it? No, it's not stored. Autistic. I put what? Do I need wildcards here?
Autism and phenotype, it was something.
Use percentages as wildcards. I can't remember if you need them or not. Does it say? I can't remember. I always do them, but I'm not sure whether you still need to. You used to. Here it is. It was added in version 21. There's the new PT that was added. It was approved. And when you click on the batch number, it gives you the information that I shared with you on the slide. Okay, for that one?
Perfect. Thank you, Jane.
My next example, any more questions?
Yeah, there's one question from Yelena. That's the usual problem. If you have two terms, so if you would split codes, you are capturing a verbatim with two terms. How would you link these two in the database? And that's always a problem, and that's why we always look for combination terms, because in many databases you cannot link these two events, and then they are separate events. You can only do so via analysis because they have, of course, the same onset date. But otherwise, yeah, they are separate events in the database and dispersed in the database.
Yeah, that's right. And often in clinical trials, we hear that organizations can't select two. It's not always possible to split code. So you may have conventions in clinical trials around which one you would have priority, or you have to ask an investigator to split. So this next one, and there's a good question to lead us on to this next example, superinfected asthma. What's being reported here? Do we need to seek clarification? What does superinfected mean? Do we need to split code? And what would be the most appropriate LLT? Again, the same questions we always ask ourselves. I've gone to my favorite Dorlands again, superinfection. This is a new infection occurring in a patient having a pre-existing one, such as bacterial superinfection in viral respiratory disease, or infection in a chronic hepatitis B carrier with hepatitis D virus. Superinfection can complicate the course of antimicrobial therapy when the new infection is by organisms resistant to drugs in use. So we've seen the definition of superinfection. What would you code it to? See your responses. Infective exacerbation of asthma is our runaway leader so far as I can see. A few people are doing asthma, superinfection lung, bronchial superinfection, superinfection. Over half of you have selected infective exacerbation of asthma. So when I first saw the term, I was thinking, are they telling us that the asthma's been infected and it's almost as if they're using the word superinfection wrongly, that it is just plain uninfected asthma, and they think that they're telling us it's an infection on top of an underlying asthmatic condition. Is that what they're meaning? Or are they telling us that the asthma was infected and it's become infected again with a different organism? So that concept of superinfection that we saw in Dorland's, that's what's going through my mind. Can I be sure that this is one infection or two infections? So let's go to the browser. Oh, I've lost my browser now because let me just close this. There's my browser. So I'm going to have a look at superinfection. Let's see what we've got in relation to, I think I've given you all the options in the poll, but let's just show you how we found them. There's the LLT superinfection. That one doesn't have any specificity. It's just infections not elsewhere classified. It's not specific to the respiratory tract. We don't know the organism, if it's bacterial, fungal, lung. We have bronchial, which is the option. It goes under bronchitis. So that gives us a little bit of doubt there, but the LLT itself does suggest it's bronchial superinfection. There's nothing with asthma and superinfection. Let's have a look at asthma and infect, and we'll get the terms that I gave you in the poll. We've got infection-induced asthma. Well, it's not that, is it? Because we know that the infection comes after. So it's not asthma that's induced by infection. So this is the term that you all liked, infective exacerbation of asthma. It does seem that is our best choice, what we've seen so far. There's an infection on top of asthma. Whether there was a secondary infection on top of that, we don't know. Infective exacerbation of asthma. It's in the infection system organ class, which we would expect and we want to see. So that seems to be the best of what we've seen so far. But we haven't got this infection on top of. So my learning points there would be to understand the meaning of superinfection, check for internal coding conventions, particularly if you're working in the area of asthma, and this is something that you're seeing a lot of. You may have guidelines, internal conventions, particularly if you're working in that area, and search for MEDRA for terms referring to superinfection and those representing infective asthma. So I still have this little niggle, this doubt in my mind. Is infective exacerbation enough? Are we happy that it is referring to an infection on top of an underlying asthmatic condition? Or is there a secondary infection? In which case, based on the LLT, I would be looking at bronchial superinfection. But I've put that as optional, because if I really wanted to understand it, as we often say, you could ask further information from the reporter, particularly if it was in a clinical trial, if it's related to a drug or trial indication. So I would agree with you on the infective exacerbation of asthma. If you're uneasy and you want to be conservative, you could use an additional secondary, a superinfection term, bronchial superinfection, or just plain superinfection. Any comments on that one, Caroline?
No comments so far.
I used to
why not selecting superinfection and infection-induced asthma?
You could include superinfection. I suppose I went for the bronchial because I thought it was more specific, although I do agree bronchitis looks like a different diagnosis. But you could use superinfection as the second term that you select, yes. I used to find superinfection terms quite difficult. I'm not sure that it's always used correctly in reporting.
Yeah, and you already explained why infection-induced asthma would not be appropriate in this instance, because the asthma was already diagnosed and it got worse with infection.
So I'm conscious of time, Caroline. We started out with 10. We've covered 6 so far, but that's because we've had some complex ones and we've taken the time to discuss. So what we don't cover today will carry over. I know a few of you sometimes ask us to extend these sessions. We feel that an hour and a half is probably enough for everyone's concentration and for ourselves. So we'll deal with what we can today and the others will carry over to our next session in September. So Caroline, I'll hand back to you for your next 2 examples.
Okay. So here we are. So our next example, our next verbatim is pimples in mouse. Do we understand what is being reported here, or do we need to query? Do pimples occur in the mouth at all? Are there any LLTs which would be suitable for coding this finding? So what shall we do? How would you handle this report? Which LLT would you propose? What would be your suggestion? So no options here, just provide us with your suggestions. Pimples in mouth. Stomatitis would be one option. So you would consider pimples is it's a symptom, and stomatitis would be a diagnosis already. Pimples refers to acne, would want confirmation or clear diagnosis term. Query if there's a diagnosis. Candidosis would be also oral bump. It's even less specific. Stomatitis. Query the site of specificity. Mouth ulcers. Mouth pustule, oral pustule. Mouth pustule or pimple. Query. So many of you are aphthous ulcer, so this would mean that pimples refer to ulcers. Query. Blister or bump. Oral bump. So you have provided quite a number of actual diagnoses, whereas pimples is just a clinical sign, mouth sores. So let me close the poll and let me switch again to the browser. Oops. Oh, why doesn't it work? Here we are. Here's the browser. And if I enter pimple in search, you will find pimple and pimples. Both are grouped under acne. So these are considered clinical signs of acne. And acne, of course, is a skin and subcutaneous tissue disorder. There's also, if I look into it, you see, go to browser. Here we are. We see acne, and there's pimples. Otherwise, it always contains acne as in the LLT name. There's also there is acne conglobata and acne pustula. Here is a pustula, so an acne that contains pustules, but again, it contains acne. So this was not reported. Papule, what about papule? Because this was reported, papule. In search. Direct hit here, if I click on it, I can see the hierarchy here in the term details window. So papule, same PT, is considered a dermal condition. And we know it's an oral condition, so a mucosal condition. What about pustule? Some of you have suggested pustule. Here it is again. It's considered a skin disorder. Pustule, it has a secondary a primary linkage to infections because the pustule contains pus, so it's considered an infection, and a secondary linkage to skin. So there's an oral pustule even. So here we have the oral pustule. Some of you have voted for it. Again, primary SOC infections, and here secondary SOC gastrointestinal disorders. So this, based on the hierarchy, would somehow fit. But none of these are really suitable, because our verbatim was telling us pimples in mouth. So let's search top down. And we are going to SOC gastrointestinal disorders. And here we will explore the HLGT oral soft tissue conditions. So this seems to be a suitable HLGT for our reported condition. oral soft tissue disorders, NEC, would be one option. So let's look for chemical burn, very specific terms here. Lip conditions, oral disorder. So this would be quite a vague term. Mouse bump is under this. Bump is, of course, could be anything, could be a mass, could be a papule, yes, could be a neoplasm, could be anything. Oral lesion, same story, very unspecific term. Oral mucosal disorder, yes, what is reported is an oral mucosal disorder, but we have the specific information that these were pimples. Oral nodule is more specific. Nodule refers to a firm, small mass in the mouth. And otherwise, there's an oral papule. Here we have an oral papule. Here it is. So that would also be an option. Oral pustule, oral papule, or something that relates more unspecifically to oral lesion. So let's search further, top down. Hemorrhages, infections, oral soft tissue, signs and symptoms. Maybe we find something there. Lip, no. Oral dysesthesia, macule, mucosal eruption, maybe something is there. No. Rash gum, rash mouth, nothing more specific. And all the other conditions, pruritus, oropharyngeal, it's more broad, nothing more suitable that we can find here. And then some of you have suggested stomatitis and ulceration. So we have the aphthous ulcer here. Aphthostoma, canker sore, oral aphtha. Stomatitis would mean an inflammation of the mucosa. And after refers to ulcerations, and this is actually not reported. What was reported were papules, a papule, or a pimple. Yeah. So this would not be suitable in our case. Contact, nothing more. Stomatitis is more vague. Chapped mouth, irritation, mouth broke out, irritation. Raw mouth, nothing more specific. Vesicular, no vesicles were reported, just pimples. So we will need to find the best approximation here to what has been reported, because there is no 100% accurate term that we can find in MedRA. So let's check some references to get some guidance how to best approach this verbatim. So this was a placement of the terms pimple, papule, and pustule, so all considered skin conditions not really suitable for our verbatim. And if we look in Dorland's again, we see that pimple is considered a papule or pustule, usually of the face, neck, or upper trunk, most often due to acne vulgaris. So in our case, these were pimples in the mouth, so oral mucosal pimples. After refer to small ulcers, such as round lesions, as you can see here on the screen, and they are characteristic for recurrent aphthostomatitis. But this would be a diagnosis. We don't know that. Stomatitis is an inflammation of the oral mucosa due to local or systemic factors which may involve the buccal and labial mucosa, palate, tongue, floor of the mouth, and gingiva. So this was not reported. We would interpret, we would add information when selecting such a term. So what needs to be considered for coding this verbatim? First, we should understand the meaning of pimples and search for synonyms or quasi-synonyms for this wording, using medical references and medical judgment. Always search the hierarchy for potentially suitable terms. The LLTs pimple, papule, and pustule are considered skin conditions in MedRA and would not be suitable for our verbatim here. And we should not make assumptions and code as reported, so not add any information. But of course, If product specifics have to be considered, you may want to contact the reporter for further clarification. Our final proposal is to go to LRT and PT oral papule in this instance. This way, we capture the affected site, and we are also in line with the definition in Dorland's, which says that a pimple is a papule or pustule. We would not assume a pustule here, an infection, because there's no indication that this is really referring to an infection. So that's our favorite term. But as I mentioned before, if you have specific products where it's really relevant to very well differentiate between the different conditions of that could affect the oral mucosa, then you may need to query in order to get additional information to better code this verbatim with a more specific term even. Any questions, Jane?
Yes, now I've got interesting on this one, Carol-Ann. This term was one that was proposed in a previous our feedback form, and the person who proposed it has come back to us and said that their final decision was to query the term, and the reporter said that it was actually oral mucosal blistering, but in the meantime, their suggestion was oral papule. So we're all aligned and agreed on what we were going to do with it.
Yeah, we expected a lot of comments in this instance. Yeah, sometimes you cannot query, you don't get more information on a reported condition, and then you have to make a decision how to best code this. Yeah.
So it's good to know the outcome of the story. Thank you so much.
Yeah.
And no other comments. No, I was just very excited to hear the end of the story for this one. So,
we had a lot of discussions as well in order to come up with our final proposal here. It was a difficult one.
A difficult, tricky one. So thank you for your suggestion. Thank you, Carol-Ann.
I think, shall we take another one or
we probably need to, do you think it's 10:33, so in the interest of time, do you think we need to leave it, or do you want to do the last? What's your next one? Yes, because the next one will take a while. I'm sorry that
it may take a while.
We will come back to it in September. I'm sorry that we run out of time. We always overestimate, but sometimes we manage 8, 9, 10. It's just this time we had a couple of complex ones. So I'll take back the slide deck and we'll just wrap up. So as a reminder, while I'm sharing my screen, that if you are here for the whole session, you will be eligible for a certificate, but if you joined late, you won't be eligible. Please do go to our self-service application where you can enter your email address, you'll get an authorization code, and you can download your password. But don't try for 2 days because our system needs time to process. So as the other reminder is that all the sessions we do this every other month now, and we have, I reckon it's probably over 200 terms that we've covered over the last couple of years. So you can look at all the recordings on our YouTube channel. So if there's nothing on the TV one evening, you're always welcome to watch one of our Let's Code Togethers back. You can find them all there. You can also find that there are the sessions from our colleagues who offer this around the world in different countries, in different languages, and our US colleagues who offer it in English. So you'll find not just our examples, but other people's as well. So the final thing, if you can spare us a moment of your time, you will get a survey by email after the session. That's our standard follow-up webinar survey. But because we like to take your examples and we like to hear your feedback as close as possible to the event, we do have this survey that you can do through the polling. So if you look back at your phone, you'll see it's there. You can tell us what you thought of the session, what you liked. Carol-Ann and I really do look at this every month, and we try to change where we can. We can't always change because you might say, let's have more examples and have them quicker. And other people will say, let's have fewer examples and have them slower. So we can't always make your comments take them on board, but we do try where we can. And we have made changes over the past 2 years. We've made a number of changes based on your feedback. And this is also where you can give us some verbatim examples. So if you've got some challenging topics or challenging verbatim terms that you feel would be of interest to the audience, put them in and we'll deal with them together in a future session. Can't guarantee when, but we look back over our pool. So there we go. I've talked over you doing your survey.
Jane, there was one question that may be worth to address as the survey is now running. So there was a question why we are not providing slides for the sessions.
We don't provide slides because we don't provide the slides because a lot of the value of the session is in the demonstration with the browser and with the discussion and the comments from the audience. You're as much part of this coding team as we are in this. So we feel the slides on their own could be taken out of context. So we prefer to just do the recording.
Yeah, fully agree.
We've got some lovely feedback coming in. Thank you so much. And yes, Mariama, you're right. We've got a holiday in between. You remind me, we've got the holiday. So for everybody, have a lovely holiday. And we will see you in September. So enjoy your summer if you're having a summer vacation.
Yeah. Enjoy the summer or other season, vacation, wherever you are.
Thank you, Caroline. Thank you for your collaboration. Always fun to work with you on this. And thank you all for your input today. And we'll say goodbye. See you in September.
Thank you. Goodbye.
Goodbye.
Bye-bye.